Hello. Today, I would like to discuss cervical lesions that require differentiation from lymph node metastasis. A middle-aged woman underwent total thyroidectomy with lymph node dissection at another hospital 5 years ago. Due to thyroid cancer with lymph node metastasis, she subsequently received high-dose radioactive iodine therapy. On follow-up ultrasound, recurrent cancer was detected in the left operative bed and left level 4. These lesions were surgically removed, followed by another course of high-dose radioactive iodine therapy. On subsequent follow-up ultrasound, a localized lesion was noted again in the left level 4. Because the lesion showed prominent cystic changes, a metastatic lymph node was initially suspected, and the patient was referred to our institution. During fine needle aspiration at our hospital, milky, cystic fluid was obtained. Cytology was negative for malignancy, and the thyroglobulin level in the aspirate was within the normal range. Based on the gross appearance of the aspirated fluid, a chylous lymphocele was suspected. Therefore, triglyceride analysis of the aspirate was performed, which revealed an elevated level, confirming the diagnosis. The reported incidence of chylous lymphocele or chyle leakage after thyroid surgery is generally around 0.52%. But it has been reported to increase to approximately 4.78.3% when the extent of surgery is more extensive. In many cases, it occurs after left lateral neck dissection, although it can also develop after lymph node dissection in other regions of the neck. If the amount of chyle leakage is less than 500 milliliters, conservative management is usually sufficient. However, surgical intervention may be required in cases with large volume leakage. The thoracic duct is typically visualized at the junction of the left internal jugular vein and the subclavian vein, and our case was located in a similar anatomical position. To diagnose chylous lymphocele, it is important to be familiar with the ultrasound appearance of the thoracic duct. Carefully evaluate the gross appearance of aspirated material after fine needle aspiration, and have adequate knowledge of this entity. With this understanding, differentiating chylous lymphocele from lymph node metastasis should not be difficult. Thank you.